better?
Yes.
Yes, sir, you may start now.
Okay, so thank you all for inviting me to give this talk and teaching on the Part 3 MRCG OSCE course for the ONG doctors globally. I am a consultant in the UK, and I specialize in gynae oncology and robotic surgery in England. So I have a lot to offer you to those who are not familiar with the UK system, and for those who are hoping to pass the exam first time or better than the previous attempt. So I will start with the content of my teaching course. Please feel free to ask questions along the way. I'll do my best to answer questions raised by anyone. If I don't know the answer, happy to find out for you. Okay, so next, please. Can the slides be, yeah. Great. So I thought for the first teaching session, I just want to focus a lot on the common themes, and they are managing difficult consultations. So it's a well-known fact that role players are going to be part of our lifestyle at work, our exam style in the access and in simulation. So, like it or not, you have to master the style, the tips, the techniques for you to pass the role player station, which I'm happy to help you out. So I've divided them into stations where you have angry patients. You will have to expect to break bad news on a serious diagnosis like cancer or premature menopause or a fetal demise. Sometimes they will pick a station where you must explain a rare condition. So you must counsel the role player, who is the patient in question, on the rare diagnosis, such as the BRCA gene mutation, Lynch syndrome, which is getting more and more popular. So these are things you got to know about. And managing awkward circumstances. So patients being a bit difficult, asking questions which you're not sure of, I will give you some tips and techniques for you to take away. So these are key words for you to commit to memory and then practice, and it will come more naturally in the exam, and it'll make you feel a bit more confident and outperform others. I thought for those who are not familiar with the UK system, I will talk a bit about the multidisciplinary team discussion. So I'm a gynae oncologist surgeon, so I talk a lot about cancer waiting times, how we run our gynae cancer services in the UK that will be probably different from where you work. The team members involved in MDT. So in case there are some of you who are not familiar at all with MDT structure in the UK, the types of cases for MDT referrals, these are very common questions raised by my junior doctors in the UK. What things to refer to for the MDT, and how do we discharge patients, and we refer them to different specialties like the liver team, the colorectal team, and the and the plastics team. So a bit about that. So at least you know how the structure work from the gynae cancer services. There will be at least one station or two station on oncology. Next, please. I thought it would be useful to go through the consenting part in the UK. So we use 4 kinds of consent forms in the UK, which I'm happy to show you some samples of it. Go through a bit about the Mental Capacity Act, lasting power of attorney, advance directive. These are key words. They are used commonly in the UK practice. When you deal with vulnerable women, elderly, with dementia, multiple medical disorders, you will come across their relative, the next of kin, using these keywords in your exams. And I thought it might be useful to really pass you so you are not surprised or taken aback by these words. If possible, I'll go through some special groups of individuals which will be picked for the exam stations and maybe go through you what daily competence is, which I believe most of you would know from reading around your reading materials. For those who may not have access to the ONG training system in the UK, like you can't get access to the logbooks, the mini caxes, the CBDs, the OSATs. I'm happy to share with you the portfolio, my own portfolio, the training metrics that you can get from the RCOG website, the curriculum that they currently use. I even give you some samples of my own personal team observation forms, work-based assessments during my training. So you are familiar as to what the RCOG expects you to say in exam to help you pass the station as though you are practicing the UK way. And reflection is going to be what they're drumming into your practice. So reflection is going to be something you must commit to in exam. And after all your hard work, you deserve a reward of the MRCOG full membership, which is why you're here today. Okay, next, please. So it's a bit crowded in the slides, and I know it's going through the ABCs. But just to make sure we are all on the same page and there's no confusion, what to do, what not to do, which I'm happy for you to ask questions along the way. I just want to go through some basic rules, some housekeeping rules. So one thing as the examiner, I find that the candidates, especially the ones from a different country, when English may not be your first language, it doesn't matter. You speak good English, but try to remain calm, remain good eye contact with the role player. Ignore the when you go into a station, look at the role player, ignore the examiner. Your eye contact is only on the role player. You are there to impress the role player. And by that, you will indirectly impress the examiner, like me. So keep calm, like you can say a prayer, you can just drink some water, have good eye contact, speak slowly, like how I am now, and enunciate your words. Because sometimes when you speak fast under pressure, under stress, it might come as a jumble, and because with the added accent from where we are from, there's nothing wrong with it. But in the exam setting, you want to maximize your chances of being given the full marks. You know your stuff and you want to give it your best. You want the examiner to pick on the keywords that you say to the role player. Okay, so when you enter the station, either virtually or face to face, depending on the choice you make, you introduce yourself. Hi, good morning. I'm Dr. Alex Tan. I am the junior doctor looking after you today. Can I confirm that you are Miss Mary Smith? And can you please tell me your birthday? That's how you should start. They're very hot on you saying who you are, asking the patient to confirm her name and birthday, and email address in some stations. And then you can start off by saying, what can I do for you? How can I help you? Sometimes if you are very stressed, you think you didn't do very well in the last station and you can't shake it off, and you just go blank. When you sit down and say, I am Dr. So and so, are you Miss Mary Smith? What can I do for you? At least they will calm you down and give the role player the chance to speak up. That's the way I would suggest you. A lot of candidates tend to jump in and say, I read this notes about you. This is why you're here today. That's okay. But I thought it's always good practice in whatever stations, whether it's a GP station, ONG station, surgical station, to say, what can I do for you? Because you're playing the game for the patient to let you into the agenda. Now, you should always apologize and diffuse the situation. You will get patients who are upset, they have agendas, they are impatient, and they're rude. I'm sorry. You have to be professional above all. So you have to apologize, even though it may not be in your natural nature. Although it may not be your fault, which is most of the time, but it sounds more professional to be the bigger person, the professional doctor, and say, I'm so sorry to hear about this. Let me help you. For example, they'll always put a station in when the role player waited for 3, 4 hours before seeing you, and you're busy managing labor wards, and you arrive to see the patient, and the patient wants to see a professor who's your consultant, and you're not a consultant in this question. You have to say, I'm so sorry, I'm not a professor, but I'm happy to take down your questions, address them, and report back to my professor, and I'll get back to you with them. That's how you play the game for them. Empathy, offer imaginary tissue, offer a glass of water virtually, although it sounds funny for a lot of you. It does shows empathy. Now, virtual exam, although it may not feel that you are there, so it may reduce your stress level, it takes a lot more effort for you to demonstrate empathy, compassion. Because if I examine you face to face, I can see your body language, I can see your anxiety and your communication better. But when you are communicating virtually and the internet connection may be a bit funny and slow, your empathy tends to be a bit staggered and not very clear. So sometimes giving tissue, here's a tissue, have a glass of water. This will help them see your empathy better and paraphrase the patient's words. So what means that you copy the patient's words. So if she said that her mother passed away from dementia, from something called diabetes, just say, you mentioned that your mother passed away from diabetes applications. So this is something for you to paraphrase. So it shows to the role player that you are listening in to their words and using it back at them. So that means you're listening very well. Um, Virtually, you can touch the patient, but if you're seeing them face to face in the station, do your best. Don't touch the patient, especially male doctors. Don't touch the patient, no matter it's within good reasons, good intention. And what I advise and what I learned from my training days, do not. There's no need to compliment on the appearance, because sometimes there's one or two station that brings up a rare syndrome, and you as a doctor being compassionate said, you are pretty, you look normal. It doesn't sound natural, it sounds awkward. Just try to avoid saying you're pretty, look normal, you're fine. Just don't comment on the appearance, be professional for the exam. So for all stations, after introduce yourself, check patient's details and birthday, and start with saying, what can I do for you? How can I help you? If they start out by saying, I'm here to see you about my results, you say, that's sure. I can talk to you about the results, but because it's my first time meeting you, would you mind if I ask you a few questions about your background? That's how I would start. You use the reason that this is my first time seeing you. Would you mind if I ask you some questions about why you're here? Tell me why you're here in the first place. Then if they're nice role players, they tell you everything. But if they're angry role players, then they start to give you, what should I tell you? Being defensive. That's where you paraphrase. Just say things like, I can see you're very upset. I can see you're very disturbed. Is there anything that's bothering you? Then try to slowly tease out the problem and then ask the history. A lot of you asked me in the past, if it's a breaking bad news, do you just break bad news and take history? I always think that without a full history taking, you didn't ask about the allergy, past medical history, past surgical history, fitness for surgery, and family history, and her symptoms and current social history. These are all the marks which are being assessed nowadays for safety. It's not just about you being competent, it's also the safety aspect. You're checking the patient. Do not have certain drugs which interact with other drugs that you're going to prescribe. Going to check you're not giving the drug that she's reacting badly to. You're checking that the patient has previous uh, surgery that make it not fit for this certain treatment option. So these are things that I would normally advocate you to um, to take before you start uh, counseling for bad news. Okay, speak in short sentences, and you can use pause. I know it's difficult, but speak slowly. How I am talking to you now, it makes you sound more in control and more calm. If the patient refuses to cooperate, there must be a reason in a script. They're scripted not to tell you until you pull out the keywords. Just say, I'm so sorry you're upset. I can see you're very disturbed. What is it that bothers you the most? What are you most upset about? Why are you upset with the system? Why are you upset with me? So at least you can get them to open up like a human being who is just frustrated, disappointed. Then that's where your compassion comes in. You give a tissue, you give a glass of water, then you slowly ask your history, and then you break bad news and make a management plan. Simple words, being very clear. If you're seeing face to face, I draw a diagram in the true exam, which I did and passed my first attempt in 2015. I drew a diagram and it helped me tremendously. I didn't have to explain in difficult words and I passed. I feel using diagrams really help to make things easier to explain, especially when you're stressed. But if you don't feel like drawing, that's completely fine. You can use your words and just speak slowly and clearly. Uh, you must maintain confidentiality. Patient's privacy is always upheld at all times. It's always good practice to check, do you understand what I mean? So when you break bad news, when you tell someone has got cancer, it's natural for us to say, is it okay? Is it okay? It doesn't sound nice or sensitive to say, is it okay? It's not okay to have cancer. I would suggest in the exam, you said, am I making sense to you? Does this make sense to you? Am I being clear to you? These are all the phrases you should take it from me, commit to memory, use it in exam, and you sound a lot better than, is it okay? Is it okay? Because we're given the bad news like, I'm so sorry, your baby has passed away, and you say, is there anything else that can help you? It sounds odd. So am I being clear to you? Is everything clear to you? Okay. Chaperone, when you offer to examine the patient, chaperone, especially male doctors. Okay. You are not a subspecialist from this exam. You are generalist even after MRCOG. So you know your limitation and refer to specialists. People like oncologists, colorectal surgeons, urologists, fetal matter specialists, you got to refer to other people. We don't incriminate our colleagues, even though we know that they have messed up in the previous encounter with the same patient. Just say, I'm very sorry. I can only apologize on behalf of my team, and I'll do my best to not let you down. Reflect, and giving feedback, especially in a teaching station, helps a lot. Don't panic. Like I said, if you use a same template, what can I do for you? Take a history, break break bad news, pick a good history, then counsel them, give them a management plan, and then summarize at the end. Summarize, okay? That will make it easier for them to understand your whole plan. And always end up with a leaflet and follow up. If not sure, leaflet, follow up. Leaflet, follow up. That's how you sound a well-rounded training doctor. Next, please. So I just want to go through with you some examples which you will come across in the real exam. So angry patients come in many forms. There will be young girls, adolescent girls, young women, elderly women with difficult personality disorder. They are scripted to be difficult with or without an underlying mental disorder that you have to take into account. They might have been traumatized from previous experience. They might have previous stillbirth. They might have previous fetal demise, previous miscarriages, multiple times. They've lost their family member in the same hospital and they're now back in the same hospital. They've been let down by a doctor seen in your team previously. So these are all hungry patients and you're going to have to deal with their remarks. I'm going to teach you these keywords. So if you can commit this to your memory. So when they start being rude to you or being abrupt, don't take it to heart. It's not personal to you. It's scripted in the station. Just apologize. It sounds a lot better. I am so sorry to hear that you waited for 6 hours to see me. I completely agree that it's not ideal to wait for so long, and it's not a safe practice. And I will make note of this, and I will highlight this to my consultant and clinical directors and managers in order, and we'll make something in place so in future, other patients won't have to wait so long to see a doctor or nurse or midwife. So this is how you diffuse them. You hear them, you respond. I'm so sorry. I agree with you. It's not acceptable to wait this long. It's not acceptable to give me the wrong drugs. It's not acceptable to give me someone else's prescription. It's not acceptable to tell me the wrong results of my scan. And I will make a note of this and inform my consultants and managers, and we'll put something in place to make sure that no one else will have to go through this ever again. This is something for you to take away. Or you say, I apologize for what's happened to you before. I hope this has not put you off, and I hope you've not lost the trust in us. I'm here to help you. Let me help you out. When they're being snappy, when they're being abrupt, because in my actual situation, this role player was like, I don't want to talk to you. It is your fault. You delay me. So in that mode, you just say, I'm here to help you. I can see you're very, very upset with the system. I apologize on their behalf, but I'm here to help you. Let me help you out. Perhaps I can do something that'll make you change your mind. See how I change my tone. That's how you make them feel better. If you maintain the same stiff, monotonous tone, they don't get the compassion, especially virtually. When you bring it down a tone down, then the role player and the examiner, like me, will feel that yes, you are taking on board what she said and ticked. So break bad news. I think all of you can break bad news. It's not something that I worry about. It's teaching how you all, to Friday. It's just that this is my style in my actual practice. When I have a patient in my clinic with cancer of the endometrium, ovarian, cervical, or vulva, I will say, I'm here or you are here to discuss your scan results with me. We discuss your entire case in our specialty discussion meeting. Before I start, what do you know about your results so far? What were you told about the scan findings so far? It's because sometimes in the script, they were told by the GPs, told by the nurse managers, told by someone else, another doctor, another midwife, which might not be correct. And you just want to catch them first, let them say what they think it is, then you can correct them. So it sounds better than having to troubleshoot them when they say, I was told the baby's fine. Now you say the baby's not no longer alive. It's going to be difficult for you. Just say, what were you told about your scan findings before I start? At least you're on the same page with them. Then I'll say your scan shows an abnormal finding of your uterus. You are in your 60s, and women after menopause should have a thin womb lining, which is at less than 5 millimeter or 4 millimeter where you work. In your case, it's taken to 8 millimeters, or in this case, it shows a complex looking ovarian mass with abnormal features. That you said, what do you mean by that? I'm concerned that with this complex mass and abnormal features, we are concerned it might be something serious like cancer. See how I break the news in slow tone, not rushing it. I've seen in the actual exam scenario how people break bad news. Yes, you will pass. Sometimes if you're up against excellent doctors who communicate very well, better than you, you won't pass because the passing mark might be raised up, and the way your dog style might not be the way that you pass. So this is the way I teach you, which you can adopt into your practice, and it will save you a lot of hassle and having to impress. Just go slow and use my phrase, and this will help you. Next, please. Now, you will come across certain syndromes which will give you nightmares. So you'll counsel a syndrome where you think they have no clue about it, like Sheehan syndrome, androgen sensitivity syndrome, BRCA gene mutation, Lynch syndrome, all these mutations which are getting more and more popular. Although it does make you panic, it make you lose focus. But if you feel that way, so do 3/4 of the doctors sitting the exam. You are not alone. So don't let the previous station affect your performance and judgment. Stay calm, learn the template, introduce yourself, confirm the patient details, ask what can I do for you, take a quick history, find out what did they know about it, and then do your best to draw. If not, explain in simple terms or summarize at the end, give them a leaflet, refer. If this is something that you are not sure of, don't make it up. Don't say things which are not true. Don't say things which sound impossible, because the examiners and role players, they experience, they know that it's not true. So you can always refer to specialists. So if it's Sheehan syndrome and you're not a specialist, refer to the consultant in maternal medicine. Okay, refer to the consultant in maternal medicine specialists, because you are not the specialist doctor. You are the generalist who knows and recognize this is something who needs a consultant specialist involvement. You refer. That's how you get the marks. If you panic and you just go around in circle, which is quite common and it's a common pitfall among people not sure what to say, that's when you lose marks, and it's a shame because you can gain marks. So for the androgen sensitivity syndrome, you can always refer. What do you refer to? Refer to the pediatric and adolescent specialists, because this usually affects young teenage girls who have not have periods at the age of 18, and you realize they got AIS. So refer them to the adolescent and pediatric specialists. You refer them to the pediatricians. That's how you get them involved. You involve the mom. BRCA gene mutation, you refer them to the genetic counselors. That's what we use in the UK. You refer them. Leaflets. If you need to, MDT. You don't have to MDT all these cases, but if it's something that's very rare, like your Rokitansky syndrome, you MDT them, because this is something to put in record, and we are able to put things in place to make the right management plan. So you can say things like, we took blood tests for you to check various hormones. We arranged a scan for you to check the glands in your brain. I'm afraid the hormone results shows is abnormal, and the MRI shows the gland in your brain, that's the pituitary gland, is shrunken. This means that you got this rare condition known as Sheehan syndrome. Then you deal with the problem. If you know Sheehan syndrome, you can say this happened because it's a rare complication after a traumatic childbirth where you lose a lot of blood, lot of bloods, and it affected your brain signal, and there is a shutdown in your hormonal function. That's it. And then you just talk about the general symptoms, and then you signpost them to the consult specialist. Let the consultants like us deal with them. Your job is to recognize that you need to signpost them to the right specialists. Don't take on everything yourself. Refer, follow up with the consultant involved. That's my tip to you. Now, managing awkward situations. It might not come out as common, but it used to be a theme for foundation years doctors, for core specialty doctors, for medical doctors. I'm sure it's not anything new for ONG doctors. So difficult situations where talk about organ donation, the respect form. So I believe most of us who work outside of UK, may not be familiar with the respect form. So respect form is now replaced the DNR form. So we don't say DNR form anymore to the role players. We say the respect form. It is a form signed, agreed by both the patient and the clinician, like ourselves. Usually a consultant sign them, not a registrar, to manage the patient with the best supportive care. So this replaces the term DNR form. It sounds better. You uphold the respect, the wishes of the patient, and it is what is the new lingo for DNR forms. You talk about the STI HPV issue among young couples, and it's always going to be something that you will deal with in the exam. So let me give you some examples. I've given you some examples already. So I apologize for bringing this up during a difficult time. This is for the organ donation. I understand there's no good time to race, but it was important to discuss this with you. I wish to share this with you that your daughter, who's in coma at the moment, has signed up for an organ donation register. I've already informed the specialist nurse in charge of this to come have a chat with you. You do not have to make a decision right away. It's because your daughter has signed up for this register. I'm legally obligated to inform the responsible officer to go for it. Okay. Now, this is the next station, the next example. Is there any questions so far before I carry on? Because I've been giving you a lot of hope some tips and key and techniques. Is there anything you want to ask? Is there anyone who wants to unmute their mic and want to ask questions?
No, Dr. Tan.
No, sir, it's very much clear.
Yeah, go on.
Hello. Yes, Dr. Tan. Good afternoon.
Hi, good afternoon. Yeah.
Yeah, this is Dr. Suparna here. I just
Hi.
had a small doubt because we have been practicing for breaking bad news as cancer. We normally give a signposting of saying that there is sinister changes. Is it okay to say that, or is it okay directly to say it is cancer? Can you help us out with this?
I'll be very honest with
Hello.
you. I'll be very honest with you. Keep things simple. It's not because you and I don't speak English. We speak great English. But to the English role player, they are more used to certain simple terms. You and I know a lot more great words to explain certain things. But what I feel working in the system is that certain words are more acceptable. So sinister is probably something I would not ask you to use. Suspicious, serious, concerning, complex are the ones that I would encourage all of you to adopt. So I make it very simple. Don't expand your vocabulary. In fact, keep it limited. Keep it very simple because the English role player are trained to understand certain words which are more relatable. So I've seen a suspicious mess. I've seen a complex mess. It looks serious. I'm concerned. So sinister, I would say it sounds awkward to some people. In real life, I don't mind at all. For the exam, use the great words.
Understand. Thank you so much for the help.
Okay. Is there anyone else? Okay. If there's no question, I'll carry on then. Now, as you know that I am a colposcopist and
So we have a question in the chat box.
Yes, go on. Yeah, the new term for DNR form, it's the respect form. So the DNR form used to be a red form. Now, if you're going to anticipate someone deteriorating and dying from terminal cancer, cardiac arrest, cardiac arrest, it's going to be purple respect form. When you say that we are going to sign the respect form, RESPECT, it's going to be yes, I can go through about the question about transgender. The respect form is the new lingo now. So I would advise all of you to drop your DNR form. Respect form is the new lingo. Simple as that. It functions the same way. Okay, it's just to make you more in tuned with the current practice. Now the transgender is going to be a big chapter. I feel at some point. Um, when you start, you can say, "My name is Dr. Todd. I am a junior doctor looking after you. May I confirm? Can I check that you are Mary Smith? Yes. Can you confirm your birthday? Yes. Now, in the transgender part, you can ask them, can I ask you what are your pronouns? These are the keywords and the new thing you need to learn now. So when you suspect it's a transgender station, it's going to be, I'm Dr. So and so. Can I confirm you are this person? Don't use the title Mr. Mrs. Just say, what are your pronouns? Can you tell me about your pronouns? Is there Miss, Mr., okay, or they? Then you go with them. You are guided by the role player. If it's going to be a woman who's transformed into a man and identified as a man, he will say, I mean, I'm a Mr. I'm a Mr. So and so. So she will say, my pronouns are Mr. and he. Then you start. Simple as that. Don't make things difficult for yourself. Okay? Don't, if it is they, if they say it's they, use they. Just use the things they give you. So the thing that to ask them is, can I just ask you what your pronouns? My pronouns, I'm Dr. Tan. My pronouns are Mr. and he. Can I ask you about what your pronouns? So my name is Dr. So and so. What my pronouns are she and she and miss. What are your pronouns? That's how you engage with them, and they know that you respect their wishes and you acknowledge their name title. Okay, now moving on to this difficult Breaking Bad news stations. I'm happy for any one of you to voice out because it's an interactive station if you want. Okay, I think someone has asked a bit more question before I move on. Um, sorry, yeah. Someone was asking about radiation and chemotherapy and the names of chemo agent needed to say to the patient, layman's term. Okay. That I can give you a short version. So assuming that you've told the patient, I'm afraid it's ovarian cancer because it's ovarian cancer, you give chemotherapy, right? I think you all should know this by this stage. Only ovarian cancer, only advanced ovarian cancer, i.e. stage 3 and 4, with chemotherapy first, upfront, usually before surgery. So you can say that we'll give you chemotherapy. These are specialized drugs given by specialist doctors called the oncologists. Usually we use two kind of drugs. One is based on taxane, and one is based on platinum, and your kind of ovarian disease respond to them. So usually the terms we use are carboplatin or paclitaxel. These are the common terms that we use in our practice, but I leave that in the hands of the oncologist. That's how you explain chemotherapy. It's usually mentioned in the ovarian cancer station when she asks you about chemotherapy. You say that chemotherapy, if needed, is given through a drip. It's given in two different classes. One that's based on platinum and one that's based on taxane. Is given and managed by the oncology team and nurses. You look after them very well. I'm afraid there are side effects, and I think the things you want to know is that taxanes does cause hair loss. So you expect chemotherapy to give you hair loss. That's it. Simple. Radiation tends to be more for endometrial cancer, cervical cancer at different stages. Usually post-op endometrial cancer, or advanced cervical cancer. So you can say that these are X-ray treatment. We divide again specialized X-ray treatment given by the specialist oncologist doctors. There's two types. You can either give you a pelvic radiotherapy, which is a X-ray radiation to your pelvis, and there's an internal radiation treatment in the vagina. Okay, in the vagina or the birth canal. So that's how you explain. So that's called brachytherapy. So there's two types of radiotherapy, depending on the specialist oncologist decision. You may have either both or one of it. One's brachytherapy, which is internal X-ray radiation in the birth canal or vagina. And the second one is the pelvic radiation. So common side effects would be skin irritation, dry skin, irritation to your bowels and bladder. So these are the things. You don't have to say everything, just the things they want you to say. And then you can just refer on a different leaflet. Is that clear? Yeah?
Yes, doctor. Thank you so much.
Yeah. Someone said, is it mandatory that we have to mention pronouns? You must understand. I don't know where you all work. I'm assuming that some of you may have worked in the UK, some of you may have not. I'm assuming that none of us have worked in the UK, but it's becoming a social expectation to address the LGBT group by the appropriate pronouns. It will look better on you if you ask them for their pronouns. Don't assume. You and I don't know their pronouns. They will feel their pronouns are the best, even though it sounds not correct. You respect that choice that they make, and you call them by the pronouns they ask you to. That's it. Yeah, absolutely. One of you talk about same sex. Yeah. So transgender and same sex relation is different. Okay. So transgender, you go through transformation, you have gender identity issue. Same sex may not change your identity. So gender and sexual orientation are different. So I'll teach you one thing. Just start by asking, my pronouns are Mr. That's me, Mr. and he. What is your pronouns? Then it sounds better. And say slowly, so at least it sounds like you care, like you're interested, like what you pronounce, that's going to make them feel that isolated, because they are a growing population and they're here to stay, and we have to accept them. And they are good. I mean, they are just deserving as much respect and rights, in what they do in the lifestyle. So we have to respect the pronouns that they use. For us to mention to them. Okay. I think I've addressed all of the questions in the chat box. I will move on if it's okay. Just so you know that if I don't finish on time, it's not because I talk a lot. It's because I've done this whole slides not thinking about the time limit. If there's anything you want to ask me to cover, I can briefly go through with you. But the whole point of me in the first session is to give you the ABCs of communicating, because it's going to be what save you for the exam. It's even the knowledge may be missing in the panic station. You by communicating calmly, slowly, clearly, the right pronouns, summarizing, leaflet, referring, follow-ups, it will make you pass, as long as you do it the right tone, the right way, the right way. So going back to stations, which will give you a lot of awkwardness. So again, Laura said that I've got cervical cancer and she has HPV on the last smear test. She never knew she got HPV before, and she read somewhere it's an STI. She's married with the same partner for all her life, and she only had the same sexual relation with one man. It's going to be a common station in your colposcopy station. Has my husband been unfaithful with me, with another person? So remember what I said in the principles. Don't incriminate your colleagues. It's less important not point fingers to the patients, family dynamics, because what you say will change and affect the dynamics between a couple, the children and the mother, and the next of kin. And the exam board doesn't take kindly into your words that will damage the dynamics of the family. Your job is to stay neutral, professional, and diffuse the situation. So if I were you, I would say it's very difficult to pinpoint. You say that your husband is the only man you've been with, but your husband may have been with more than one person before he met you. So when you have sex, you will pick up HPV naturally. It's the way of life. And your husband will have carried different strains of HPV way before he met you. And it's unfortunate. It doesn't mean that it will become cancerous for those people and your husband when they have HPV. It is unfortunate that it became cancerous for you, but I'm glad that you're treated appropriately. But having HPV now, it doesn't mean your husband has, has been seeing another person behind your back. So that's how you diffuse the situation. You want to say that I don't think so. But you can't say no because you've got no evidence. Just say, I think it's unlikely because of this reason, and said, so I don't think it's likely your husband has, has been seeing other women or other men. So I don't want you to get too worried about this. That's how I would talk in the exam in real life. They ask me a lot of things. I've got a real patient with cervical cancer refusing to have sex for for at least a year after she's finished her chemo radiation. Because again, she read that HPVs cause cervical cancer through sex. So she refused to have sex with her husband for a year. And when she came to me for follow-up, I said, I understand that you were traumatized by your treatment and the cancer diagnosis. We are now looking after you. The moment you feel unwell, we will be right away to investigate and treat you. So I think it's not, be kind to yourself. It's not unrealistic. It's not unrealistic to start having a healthy sexual life because it may have changed since your treatment. And also it may also you also want to redeem your husband sexual relationship. So these are all holistic in improving the patient's family dynamics. Okay. So next one is obstetrics. Sarah Cooper. I am now 39 weeks pregnant. I was seen last week in MAU, is the maternity assessment unit, due to reduced fetal movement with scans and CTGs. Everything was fine. And I was asked to be induced for my labor early. My request was declined by the doctors or midwife. I was told to wait until 41 weeks and to consider an induction by then. You came back and now you found the baby has died, and it's your fault. So this is going to be quite a recurring theme in exam. They want to see two things. Number one, you break bad news. Number two, you manage a situation not expected to happen. So no matter what you and I do, despite our best efforts, poor outcomes are going to happen. Things that are not meant to happen will affect the ones we don't expect to, even the ones who are deemed low risk. So if I were you in this position, I'll begin to say, I'm very sorry for your loss. I can't begin to imagine what you must be going through. It must be, very, very upsetting for you. Keep it simple. I know, as one of you said that you want to use words like sinister, you must be devastating, you must be disappointing. Those are fine. You can say that. You can say that. I think you can say devastating, disappointing is more powerful, but don't get too creative with your words. Just focus on the problem. I'm so sorry for your loss. I can't imagine what you're going through. It must be devastating for you and your family. I've been through the notes myself. I've discussed it with my consultant and my team members. And as much as I agree with how you feel, I must legally inform you that everything was done within the right reasons and the right indication. So the midwife and doctors have checked you with scans, baby straight traces, measurements, blood pressure and pulse. And at the time when you're 39 weeks, we couldn't find any reason to induce you early, because sometimes early intervention may bring in needless complications, and some patients, some of the patients might end up having unexpected complications, which is something we don't want. Which at the time when we check you at the 9 weeks, we could see no reason to expedite, to fast track your delivery by induction. That's why we discourage you from being induced so early, and we told you to wait at 41 weeks. Given this situation now, we will look after you now, and we will deal with it in the future. When you do get pregnant, we will see you a lot sooner, and we'll plan something earlier for you. This is something just to tidy up for them. So at least they feel that you are listening, absorbing their frustration, their information, giving them an appropriate plan. And it's a pass. Next, please. Yeah. So just a few more stations. If it's something you want me to move on, I'll move on. Okay. I'm happy to move on if you want me to. Now, as I said, when you counsel for certain things, you expect to counsel for uh screening tests in the first and second trimester in pregnancy. Down syndrome, spina bifida is going to be some, and other fetal anomalies are going to be something you must be able to convey, to tell the role player some information before you refer on to the fetal specialist. So Tara had a first trimester screening for Down syndrome. It was low risk. The rest of the pregnancy scans were normal. But in the actual birth, she was told that she had a Down syndrome baby. In this station, she said, "How is this possible? There must be a mistake in your test. You're giving me the wrong information." Now, this is an actual station in 2015 when the role player was furious, angry, ready to pick a fight, and all you do is just diffuse, diffuse, diffuse. Apologize, 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 explain to them. So, we all know, you and I know that the Down syndrome screening test is about 85% sensitive. It misses out about 15% of of those with actual downs. So in this case, I'm very sorry that we have let you down. But it is done within the right reasons. The tests were done at the right time. It's done appropriately to the right standards. It's been double checked by our system, and the doctors and midwife have checked you for scans. And along the way, there was no concerns that Down syndrome was an issue. But having a Down syndrome at the end of pregnancy is devastating for you or disappointing. But it could be that there were subtle features of the Down syndrome that no test or scan will be accurate. This is how you should say it. Just to explain to her that there's no 100% foolproof. We do our best to make sure that you're safe, but you must know that you are low risk. It doesn't mean that there's no risk. The test itself is not the best, and we have done everything, the checks all correctly. Along the checks, there's no signs to make us worried. At the end, you have a Down syndrome baby is understandably upsetting, but we will support you. So there is a question I see on the chat box. In the intrauterine fetal demise, sometimes the role player insists they're blaming me or my colleagues. So how do you counsel with viewers and get back to consultation? They are scripted. They're scripted. So if they blame you, it's not personal. It's not you're being mucked up. Just recognize it. It's very hard for you and me. I get it. We're all humans. We work very hard as doctors to be perfect or almost perfect, but we are let down by psychs. So if the role player blames you, just say, I'm very, very sorry. I can understand why you would say this. Don't say, can understand how you feel. Don't say that because it tends to be the words that come out from your mouth just out of practice. Just say, I can understand why you say this. I can understand why you're upset. Upset is angry, okay, in this sense. I can understand why you're upset with me. I can understand why you say this. Just don't take it personal in exam. Just say, I will do my best, and I'm sorry to hear about this, your loss, and I'll do my absolute best to help you and support you in this setting. You're here now. This is a safe place for you. I will make sure that things are done correctly for you, so you're well looked after, and I will make sure that my consultant will see you and give you the necessary advice so that you have the right information. So although they blame you, it's very hard and you're very stressed. If you adopt my system, my template, it's very resist to get angry or get offended because we all want good outcomes. We all want to make them happy, but we're let down by psychs, and nature is much more um much more difficult to predict than science. So you just have to say that I'm very, very sorry. I can understand why you say this. I can understand why you're upset. I can understand why you want to complain. In fact, if you want to complain, I'm happy. I'm happy to provide you some information to complain, which is the PAL service, and you are encouraged to list out your concerns, and we as the team we will investigate, and we will give you an official feedback at the right time. But at this moment, let me help you. Sounds better? Let me help you. You're in the right place now. Let me help you. Okay. I understand that this is something that a lot of you know it. You have worked very hard to get to the stage. These are all the tips and tricks and the subtlety, the difference that makes someone pass or not pass. If you adopt this way, I'm sure all of you will pass. It's just that how you demonstrate your performance in exam, that makes a difference. Okay. So moving on to the next one. I'm in my second pregnancy with previous ectopic topic, treated by surgery. Now, in this pregnancy, there is no viability. So a second recurrent ectopic is made by the doctors. My hormone levels are static, 987, and then 1,100. Instead of acting on it and giving me treatment, the doctor kept me in the hospital for 3 days, ignoring me, denying my treatment. I'm not sure what your practice is when you have PUL, like this case. In the UK, when you have PUL and the patient might have some aches and pains, it's always safe for the junior doctor to admit, because at hospital admission, although not necessary, is still a safer practice than sending her home, blindly expecting her to manage herself. So if not sure, you admit. That's what happened to her. Admit, observe, hospitalize, and then re-evaluate the plan. So now she said that you denied me my treatment 3 days ago, and it's confirmed. It's not a topic. It's not a viable pregnancy. It is your fault that another topic because you delay me from having the treatment at the right time. So now I'm gonna have skin surgery, which is going to be horrible for me. This is my true station in 2015. So and the role player was an angry role player, and can you imagine you're already exhausted, you're tired, you just want to perform well, you just maintain your calmness, and again, apologize, say that I can't imagine what it must be like for you, I understand why you're upset. The reason why we admit you is because this is in this is in keeping with our hospital policy. When you have something called PUL, pregnancy of unknown location, it is our safe practice in all hospitals here to admit you to hospital, observe you, discuss it with the consultant involved, plan the right treatment. It's not because we delay a treatment, it's because some treatment changes over time. So we have to admit you, observe you, and see how things turn out before giving you the appropriate treatment. Understand that you may think that we're delaying you, but it's not what it is. And I'm sorry for how you feel. Now, given the situation now, you don't need surgery. I'm offering you a specialized medical treatment, which is methotrexate. It's given for recurrent ectopics, for certain conditions. They ask me in exams, what are the conditions, what are the levels, how do you give it? That's when you can carry on your knowledge. Because she was so angry, she clamped up. She said, "You can't ask me any question. I don't talk about it. It is your fault, your fault, your fault." You can always say that I'm very sorry. I'll do my best. I understand your problem, and I would make an official report about your case. So our team will discuss it and we will learn it for our future practice. So at least the patient knows that she is a difficult case and we're taking her seriously. That's what I would do. This is my actual exam station, which I remember. Okay, next, please. Okay. I think I've done the first part, which is all about communicating how you approach a difficult group, special situations, and you know, and how to diffuse an angry, frustrated person. Is there anyone wants to ask me before I move on? How will we time, by the way? Are we okay with time? Okay, so okay, so I would move on if you don't mind me. I will move. I'm not sure. I'm sure you all know about this, and you have read about this in your part two. You've done very well for part twos, and it's just something just to refresh your memory. So you are applying this in you know in the OSCE setting. So when you refer to gynecology MDT, uh, the whole point of MDT is that we don't believe in single solo leadership. We believe in multi-systemic, multi-specialty leadership. So we believe in team working, collaboration, inclusivity, and being compassionate. There's no more about we are trying to do away with hierarchical leadership, dogmatic opinions. It's more inclusive, equality, and collaborative. And this is what we're moving to for the future doctors. When it comes to working together, we must always take into the patient's satisfaction because working together means the patient's needs are met and they will be more satisfied, and you can reduce stress among the staff and the healthcare. And the consultants, the leaders, thought to be the ones driving this forward and to facilitate effective team and inter-team working. And we're trying to do away with the authority gradients, which is the hierarchical titles. Next, please. Just to summarize from this points that I'm sure most of you, or all of you would know from your part two exams. In summary, when a person is suspected to have cancer, they'll see the GP first, who's a primary care physician, and they will be referred to see me, specialists, within 14 days, which within 2 weeks in my rapid access clinic. From then, including the 14 days, we have 31 days to confirm the diagnosis of cancer. So we do all your hysteroscopy, your colposcopy, your laparoscopy, your CT, your MRI, your PET scan, and biopsies to confirm the cancer diagnosis. Once we confirm the diagnosis within 31 days, we have a second 31 days, i.e., 62 days from the start of referral from the GP to us to treat the patient, whether by medically with your coil, your pill, or your uterine artery embolization, for example, or you give them surgery, which is by laparoscopy, open surgery, or robotics, or you decide that the patient's not fit for surgery or not fit for treatment, and you give them best supportive care. So this is when we all had to plan for all our patients suspected and confirmed of cancer. We have 14 days to see the patient, and then 31 days to confirm the cancer, 62 days to treat the cancer. This is something you must know for your exam. Next, please. Okay. So as I said that in the person in question with suspected symptoms will see the GP. The GP will do blood tests, your CA125, your scans, and then refer to see me. And then they usually send a form, a referral form, which is a template. It could either be one of the 5 cancer, which is endometrial, which is the most common, or ovarian, cervical, vulvar, vagina, and sometimes other coexisting cancer, which happen to have gynae symptoms. Then from this, the patients will have tests done, and all of these patients will be discussed in our MDT. Okay, so the MDT, as you may or may not know, it works by breaking down and triaging them into I mean, is it a question of cancer? Is it a benign case? Is it treatable? And is the patient fit? And how can we treat them? Oh, when we sorry, practice session. Actually, if you want to practice with me online now, I'm happy to skip forwards. You can unmute yourself. I will assess you and see how you respond to me. Is that better than you having a full 10 minutes, and then I'll want to get your response and see how you deal with it? Is that okay?
Yes, Dr. Tan.
Okay. So in that case, let's so one person asked me, can we do some practice station? Yeah, sure. If there's something you want and you feel that it'll benefit you, which I do agree. Okay, let's in that case, next please. Next until I see some scenarios. Yeah.
Okay.
Yeah. Next, please. Next, please. Yeah, keep going. Sorry, yeah, sorry. Now go back. Now go back. Go back. Go back. Okay, sorry. Go next, please. Stop there. Perfect. Now, whoever asked me that question, are you happy to unmute? Are you happy to unmute yourself? And do you want to open your camera so I can see your face and we can see how you communicate? Would you like that?
Y- yes, sir.
Sorry, I can't see who's talking. Yeah, I'm. Let me
My
see.
name is Dr. Maktul Fatma.
Hi. Nice to meet you. Nice to meet you.
Hello, how are you?
So I'm trying to open up. Yeah. My thing. Okay. So do you read the first scenario?
Okay.
Read it for me, please. Read it for me.
Okay, Jane Smith, 826, referred from GP to the gynecology due to the abdominal pain and bloating. Getting married over the next 4 weeks. Pelvic ultrasound showed 10 centimeter complex looking ovarian mass with multiple loculations, capillary projections, and solid components.
Now, assuming that you have introduced yourself, you check that I'm Jane Smith, my birthday, and the right age, and you ask some history about me. Okay, you know enough. Okay, counsel me. Start. So, doctor, I'm here for my scan results.
Jane, I have your ultrasound report, and before going on a discussion, I just want to know, do you have any idea about your ultrasound results?
Not really. I saw my doctor because I've been having this bloatedness and this discomfort. I want to look good in my wedding dress because I'm getting married next month. I mean, he said that he'll book me for a blood test and a scan. So I don't really know the results.
I understand your concern, Jane. So, before going on a discussion, I just want to know, do you want me to call someone to support you in the discussion, Jane? I have
Oh,
some concerning news to discuss with you.
okay. Actually, my fiance is out of town. He's coming back 2 weeks later, next 2 weeks, because he works abroad. He travels a lot. He's not around, but I live with my mom. So I don't have anyone here today. Do I need to call my mom?
Uh, if you want, we can call your mom, and we can wait for your mom to arrive. But if you want, I can go ahead. Is that
I
okay for
would
you?
suggest that you are the doctor in charge. You will say, I would strongly encourage you to call your mom.
Okay. All
Okay?
right.
I would strongly encourage you to call your mom because this is something that I would prefer someone from your family to be here for support. That's how you should talk.
Okay. So, Jane, I would strongly suggest you to call your mom because having some family member to support you right now, it's very important. So, because I will give you a lot of information, so having two heads to process this information would be better. Are you
Okay.
getting me? What I'm trying to say?
Yep. I've called my mom. So can you tell me my results, please?
All right. So, Jane, I have your reports. I have confirmed your details on your report, including your name and NHS number. And I'm really sorry to tell you that, Jane, your ultrasound report is showing that you are having a complex mass in your ovary. And right now, it is not looking, it is not look innocent looking. I'm really sorry to tell you about this.
I don't know what this means. I don't know what this means to me.
Jane, let me draw for a better understanding. This is the womb, these are two tubes, and these are the ovaries. Every month, the ovaries produce an egg that is for the getting pregnant and getting period every month. But sometimes what happens, fluid-filled cysts become in the ovary, appears in the ovaries, and sometimes these cysts are not so simple. They have some complex features, and these features are not innocent looking. And right now we have to investigate more to get the uh, confirmatory results. But right now it seems that uh, it might be a cancer. I'm really sorry to tell you that.
Okay. I'll give you a good okay for that, but it can be better. I mean, it's a
Mhm,
lot of talking for the same thing.
mhm,
Just say
mhm,
that we scan you for ovaries. These are the two organs in your pelvis that produce eggs every month. In your
mhm,
case, the left ovary, okay, or right ovary looks
mhm,
suspicious. Usually they have abnormal features, okay, abnormal
mhm,
features, and they've grown to the size of 10 centimeters of
mhm,
10 fingers. This is
mhm.
not normal. See how
Okay.
I tell it. See how I explain it. You are not wrong. In real life, that's fine, absolutely fine. But
Mhm,
in the exam, right, you want to say it with a punch. Just say that
mhm,
you have two ovaries in your body that produce eggs every month.
mhm,
One of your ovaries appeared very abnormal with abnormal features and it's grown
Mhm.
to 10 centimeter of about 10 fingers big. It is
Mhm.
huge. And I'm concerned it's something serious. That's it.
Mhm.
Do you see
Okay.
how I talk?
Okay.
Okay, not because I know more than you. It's because I
Mhm.
do this every day. And I find that this
Okay.
is more effective. Your way of talking is fine, but it's not effective. The way I
Mhm.
talk is right on. The patients will know in my clinic, they know what it means. Okay?
Okay.
Carry on.
Okay.
So, okay, what do you mean, doctor?
Um, Jane, it seems right now what we are concerned that is cancer of the ovary. So we don't know right now if it is cancer or not. So that's why we need to do some more imaging and some test. So after getting these imaging and blood tests, the team of the doctors will sit together, including my consultant. There will be the cancer specialist doctor, nurse, and then we will see that either it is a cancer or not. Am I clear so far?
But wait, I'm getting married next month. And this is not something, can this not all wait until I get married and go on honeymoon?
I totally understand. I can see that how why you are saying this. If I will be in your situation, I will say the same. But again, your health is right now very important to us. So if in case it is a cancer, um, uh, uh, it is very important that we should start treatment as early as possible before getting any serious side effects to your body, because you're 26 years old and you are young, you have a life in your ahead. So it's very important that we should know the depth of this problem and we should make a right treatment for you. Is that okay
Yeah,
for you?
yeah, I mean it's a good answer, but I would say um I will say I changed a bit of words because that's how I would say, okay? Your
Mm-hmm.
health is our priority. Okay? Sounds
Mm-hmm.
better, yeah? Your health is my priority. Your safety is my priority. So I have to make sure that I'm doing the right thing for you. Understand that
Mm-hmm.
we're getting married and having a honeymoon is most people's dream. And this comes at the most unfortunate timing. But I will not be doing my job as a good doctor if I say we can delay this test. And because your health will be at risk.
Mm-hmm.
Do you see the difference? You are correct, I'm correct. But it may be my word has a bit more punch to the tone.
Mm-hmm. Mm-hmm.
Okay? It's
Okay.
more effective. Okay?
Mm-hmm. Okay.
So what blood tests are you, I mean, what blood tests and scan would you be doing for me? I mean, I'm good. I mean, I don't want to have x-rays in my body.
Mm-hmm. Jane, I understand. The blood test, what we will do that we will measure certain proteins in your blood, like which these cancers has released in our body, in our body. We will measure those protein in your blood. They are not X-ray. And the other test which I am asking you, that is MRI. Have you ever heard about this?
Okay, let's go back. Okay, let's go back. Ovarian cancer in the UK. If okay, you are not wrong by saying MRI. If it's a
Mhm.
benign ovarian mass or benign ovarian cyst, MRI. I agree. But if assuming this is cancer, okay, that's what you're doing it, right? If your CO25 is over 200, 300, 1,000, okay? And for ovarian cancer, urethral ovarian cancer, you do a CT scan. But you're right, MRI is correct. But let's assume it's cancer, okay? It's suspicious of cancer. Hence, I put down period projections, solid components, multiple locations. But not wrong to say MRI. But because you don't, sorry, do you do oncology work like me?
Yes, I'm doing oncology clinic with my consultant. This was the question, Dr. Tan, which I asked my consultant. So he told me that nowadays they are doing MRI, and if there will be something like to see the metastasis in the abdomen, or then we will do the CT. Like they are doing
Um,
both MRI plus
He's
CT.
not wrong. He's not wrong. It's the resources and the special
Mhm.
skills. As you know, globally, there's far more trained specialists for CT than MRI. And
Mhm.
MRI is more expensive. MRI happen far less often and less frequent than CT. CT, okay, 10 seconds done, okay? But MRI takes at least half an hour. And I'm not sure if you realize it's becoming a trend now for all these patients to be phobic of space. But it's not wrong for MRI. I'm just saying that in case if you don't do oncology for the ones out there, CT is not is the way forward. Because why CT? You do a whole body CT staging, chest, abdo, pelvis. Your
Whole
MRI,
body.
yeah, your MRI. Yes, someone said that 6 years old. That's correct. If it's a benign, okay. Let me rephrase, okay? If it's a benign ovarian mass, if it's a benign ovarian cyst, MRI. That's I agree as well. That's for me. But in the exam scenario, when their signposting knew there's going to be a cancer station, so they got ascites. They see ascites, in the ovary. They see a complexity, this vascular. It's got Doppler positive, CT, CT, CT.
Okay.
MRI
Okay.
is only if you think it's benign, if it's endometriosis, if it's something that's not cancerous. If it's cancerous, you need the full staging. Is that clear to everyone?
Yes, ma'am. Dr. Tan. But as you asked that I don't want any radiation, so what should I say in that?
Sorry?
As you asked as a patient that I don't want any radiation in my body,
Yeah,
so what should I
absolutely.
say?
I completely agree as well. You can say like, Jane, understand your point and understand your concern. But usually, and I would discuss it with my consultant, and we can maybe change it to MRI, which what this person say, right? Uh, MRI is what we use for young people like you, and we may use it. But when we suspect something serious like cancer, the MRI doesn't cover your chest. You need to
Okay.
do the CT scan for your chest too. Maybe you can do MRI, abdo, pelvis, and chest CT. But a lot of you who don't do oncology work like me and you will get confused. So it's best to see CT. One CT, more than enough. CT,
Okay.
more than enough. And then you discuss it with
Okay.
your consultant. Okay? I understand this. Someone asked me about MRI according to your aorta. Absolutely correct. But if it's a spread of cancer, MRI is not. It's not for ovarian cancer. It's when I wouldn't use MRI for ovarian cancer that often unless it's a young girl and you want to do fertility sparing surgery. This is what I would do. Okay, so it's so carry on. So I'll say okay. I'll think about the CT scan then. What will happen now?
So once we will get the results, Jane, the team of the doctors will sit together. We call that the MDT, and that will include my consultant. There will be the cancer specialist doctor, cancer specialist nurse, the imaging doctor, and the pathologist who look the tissues under the microscope. Okay, and there will be the if needed, we will involve the dietitian and counselor as well. They will all sit together, and then they will make the management plan within 2 weeks. We will call you for the discussion on the plan. And most I'm afraid if it will turn out into the cancer, Jane, then uh, you might need a surgery that we call that the staging laparotomy, and it will be done by tummy, through the tummy. We will give you up and down the incision, and then we will look into the matter. It will be done in the specialized center that we call the cancer specialist unit. And before this, we will optimize your health. Okay, and we will support you as much, because in NHS we have a lot of help that we can provide you. You're not alone. We are not abandoning you. Okay, we are here for you. And as you are
That's
26
very
years
good.
old.
So sorry to interrupt you. That's very good. It's all the correct information. Remember to break them in pauses, okay? Now, MRI thing, CT scan is been addressed. Someone has said that MRI is more useful for endometrial, cervical, and vulvar cancer, which I agree.
Yeah, so this is for the more soft tissue,
Sorry?
soft tissue
Yeah.
staging.
Look, okay, soft tissue cancer like sarcoma, I'll do
Mhm.
both. I'll do both.
Okay.
But make
Okay.
it simple for all of you, okay? All of you out there, don't, because it's a generalist exam. Don't
Mhm.
don't be too worried about MRI or CT. In cancer diagnosis, CT staging. MRI
Mhm.
is more for like this person said, it's endometrium. That's correct. Cervical, absolutely correct, and vulva, absolutely correct. But I'm seeing my hospital, because they can't cope with the workload and resources, they're trying to cut back on low-grade endometrium, very small vulva cancers. Cervical, always MRI. But these are more for me to know, not for you. Okay? For
Mhm.
you, you tell her MDT, you treat her. Now, you can say that you're giving her digital laparotomy. Yes, that's fine. There's something you're missing. She's 26, about to get married.
Yeah. So what I'm saying that as you're 26 years old, so we will have a meeting with you with the fertility specialist as well
Excellent. Excellent.
before going on a surgery, and we will tell you that, and we will discuss with you, and we will respect your wishes of the like for your fertility, and then we will discuss the management plan, like what we can do best for you.
Excellent. So if you any of you see this in exam, fertile nulliparous woman about to have a suspicious ovarian mass and a risk of debulking laparotomy that will render her infertile, you got to refer for fertility counseling before you operate on her. It's
Mhm.
good practice, and sometimes the RCOG might even fail you because you just jump into surgery. Although people will argue that cancer trumps fertility. That's correct. But young girls, they do uphold fertility wishes, so you got to involve fertility specialists. In actual setting, a lot of these women would forego it, and they would say, just open me up and treat me. I want children to survive. This is what most people would do. Only one or two I've seen for the last 5 years would just say, I'll get pregnant or whatever. But it's good practice. That's excellent. So this laparotomy, will it be done by yourself?
No, it will be done by a cancer specialist doctor. That can be a gynecologist, oncologist, along with the cancer specialist surgeon. So
Yeah.
it will be a
So
like teamwork.
what would happen in the operation? Tell me just yeah, in the operation setting. You do a midline laparotomy. What else?
Jane, before going on a surgery, the sleep doctor will meet you. Will discuss the sleep options, anesthesia options for you. Okay, and I will tell you that once you will be ready for the surgery, we'll put a rubber cannula in your arm. We will take you to the surgery. You can it can be like putting you in the sleep, or giving you injection in the back. It will depend on the circumstances, and then after giving you anesthesia, will give you upside down incision, and we'll open your tummy. We will look inside that, if there is any spreading of
I
this
I
cancer.
I think you know the answer, but you're just making too long a sentence. Try to make it short.
Yeah.
Remember, short, short, short. Just say that this major operation will be performed by a specialist cancer gynecologist surgeon like myself. It'll be
Mm,
done in a center hospital. You'll be done under general anesthesia. You'll be asleep. It'll be an up and down cut in the middle to expose your abdomen and pelvis to to allow us to assess the spread of disease. We know so the scan we can sort of predict. We can predict, but the surgery is when we know for sure how much spread there is and what to operate on. So okay, what would you take out in the operation?
yeah, then we will see that if there will be any fluid collection in your tummy, then we will take the samples. And if there will be a secret will be spread outside in the lining of the tummy, then we will also take the sample from there. We will check your liver, and then uh, uh, the surgery will depend on and your fertility wishes, that how much the disease is spread. Okay,
Hmm.
we will take that mass along with that ovary, and we will check the other ovary and the sides of the ovary as well. If you will opt that you just want a removal of the mass and ovary, then we will remove that mass and ovaries, and we will take the samples for any suspicious area, and then we will close you. But if I'm really sorry to say that if the cancer will be spread more and it will not be possible to save the tubes and ovaries and your womb, then I'm afraid that we have to take your both ovaries, tubes along with mass and womb.
Okay, you're not wrong by saying that. This is only I'll tell my patients of this age if she's got stage 3 cancer. It's either operate on you if it's operable or chemotherapy. You by saying that, okay, you are not wrong. Let me correct you, okay? You will do an up and down laparotomy. Do you know what is a frozen section?
Yeah.
Yes, if just say it in exam, like we will do a quick
Okay.
check of the exact of the operation, the time of operation in the first few hours to confirm if this ovarian mass is suspicious or not, because it gives us a degree of confidence if it's cancer. If it's cancer, then sadly we have to proceed with the full hysterectomy and full surgery, and this will make you infertile. But you can do a frozen section, and this is how we check. If it's not cancer, we close you back. That's all. And can this be done by laparoscopically or robotically?
Um, it should it can be done the robotically, but it depends on the expertise. But the cancer surgery is usually done by the open surgery, I'm afraid.
In the exam, that's correct. In real life, once you're the consultant, once you're the consultant, you can do what you like. I mean, I can not do what I like, but I would suggest the best practice in the world is open surgery, because to contain the ovarian mass in case it's cancer, to avoid spillage. But once you open, it's spread, then you do a full hysterectomy and omentectomy and lymph nodes or whatever. But if it's open up, frozen section, confirm if it's just example endometrioma, or if it's just I've seen rare cases of benign teratoma with carcinoma tumor. So we don't know. That would tell us for sure. So at least you know that excision laparotomy is for frozen section, ovarian, and then proceed depending on how things are. But before the operation, you must refer for fertility counseling. That's the gist of this station. Is that clear to you?
Okay. Yes, Dr. Alex. Yeah.
Do
Thank
we
you
need
so much.
Okay, we got time for another one. I think that, sorry, someone asked in the thing, how do you say frozen to patient? You can say that it's a quick bedside test at the time of surgery where we remove the whole ovarian lump and intact, and we send off to the laboratory. They will deep freeze the entire specimen and biopsy the most abnormal area to confirm if it's cancer or not. If it's cancer, we will proceed with the full cancer surgery, as if hysterectomy or mastectomy, lymph nodes, appendix, and beyond. That means you will be infertile. But if it's endometrioma, if it's just benign teratoma, if it's a fibroma, hallelujah, closer, okay? Closer back. Yeah.
So,
Repeat last point about laparoscopy. Laparoscopy and robotic, I trained with one of the best surgeons in the centers. We best not to do laparoscopic and robotics for a huge mass at 10 centimeters, especially cancer, because it's not ethical, because it's going to be that patient suffering if you spill it. So always open surgery in exam. Okay, for the
yeah,
exam,
open surgery.
simple. When you become a consultant and you want to do it laparoscopically, robotically, as long as you know how to contain it, like I know when to contain or not. I know tricks to contain it or not. But when it's all stuck due to endometriosis, it will burst, and then you will upstage it to stage 3 at least. So that's when, because stage 3 means that you must give chemo. Okay, good. Have I answered most of your questions, and I hope this is being useful for you guys.
Yeah, very
I
useful,
think you all
Dr. Alex.
know your substance. You just need me to just re-emphasize
Really,
certain key points, so you
yeah.
know how to say things. I've been through it myself. I know, I understand how you feel. Yeah. So if you don't mind, I'll move on next person. Okay.
Yeah,
Uh,
sure. Thank you.
Next person can do Brenda Higgins. We can talk. Yeah. Sorry, it's all about gynecology, breaking bad news. I'm sure you can do it for fetal demise, premature menopause, PCOS. Sure you can. Just anyone can volunteer. Have I
Dr.
lost
Tan,
it?
one question with the previous case. What if the patient, since she's 26 years, what if she just asks us whether we can spare her other ovary? How
Mm,
do we
mm.
answer her?
Absolutely. It's a good question. So blame the signposter to the MDT. Your job is to triage her signposter. That's how you pass the exam. Just say that it's a very good question and it's always a common question raised by youngsters like yourself. We discuss all your cases in our specialist meeting with the surgeons and oncologists, and we'll decide what's the best for you. Before they plan a treatment for you, they usually refer you for fertility counseling. So why do I save the time for waiting and send you to the specialist now soon, so you get counseled by the right team before you see the cancer team will give you the treatment. So depending on the stages of your disease, if it's cancer, it depends on spread. If it's if it's early stages, we can still save some organs. We can still save your fertility. But if it's advanced cancer, I will still would like you to see the fertility specialist first, but usually your fertility treatment will be more limited. Is that clear?
Yes, doctor. Thank you so much.
It depends on the spread of
And
disease. Yeah.
yeah, Dr. Alex, can we offer a frozen section of the other ovary at that time? Like, can we do?
Fro you got to be rich because you got so how it works is that the pathologist have to be has to be contracted, has to be on standby for you to do the first
Yeah.
section. So what happens that if your case gets delayed, like for example, you got a minor, major, and your major is this case, your minor will be prolonged of whatever reason, and this same doctor is paid and contracted to wait for you to give out your
Mhm.
your specimen. So what means that you can only first section one specimen,
Okay.
in
Okay.
this system. So either in the books you see lymph nodes, um I think there are skilled people around, but they choose easier ones because lymph nodes takes a long time. They must ultra stage, especially for certain nodes. So
Mhm.
they rather frozen section ovarian masses, followed by uterine masses or fibroids, and lastly lymph nodes. Because I work with one of the best centers, they tend to frozen all ovaries easily. Uterus, they grumble, but they do it. Lymph nodes, no. They need a few days. I think globally, people need a few weeks to count lymph and ultrastage them, but this team of pathologists does it in a few days. So you can only position one specimen for one patient. Is that clear?
Okay. Okay. Yeah.
Does
Yeah.
that answer
Yeah.
to you?
I
You,
understand.
you, you section the most abnormal looking feature. You
Yes.
can
Okay.
biopsy that the other ovary in case it looks some mat deposit, but they can do it for you. But
Okay.
the whole point is that if you see mat is confirmed it's cancer. It's
Mhm.
stage 2. Oh, sorry, 1B.
Okay.
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 Anyone else want to volunteer for number 2? Then we can how will be time, yeah? We can do one more. Hello? Anyone
Yeah,
else?
I'd like to have a go.
Yep. So I can't see your faces. I can hear your voices. Go on, go on. Yeah, go on. I'm Brenda. Go on.
Where do you want me to start from?
So you say who you are. You confirm it's Brenda. You asked me the history already. You now break bad news to Brenda. So doctor, I came back because I received a letter about my results from my camera test. Can you tell me
Yeah, but
what is it?
Brenda, have you got anyone with you whom we can discuss the results with alongside with you? Just because I'm going to be giving you some really important information.
Very good, very good. No, my husband doesn't drive. He's got Parkinson's. I'm his full-time carer, so he can't drive. In fact, my niece comes by twice a day to look after him. So he's not able to come at the hospital on short notice. I don't have anyone at the moment. It's just me and him. We don't have children.
Okay. I'll get my specialist nurse in here. So we can.
Yes, that's correct. Yeah, go on. Yeah. Okay.
Brenda, I have your results here with me. I have confirmed your name and your age and your hospital number. And I'm afraid I've not got I've not got good news for you.
What do you mean, doctor?
The results, your camera test, when we did your camera test, we took some tissue sample to check to rule out any sinister cause. Unfortunately, it has come back to show that you've got cancer of the uterus, of the womb.
Oh dear. Well, are you sure about it? I've heard of people having cancer and then it goes away and it's a mistake.
I'm so sorry. I have checked with I've checked these results. I've checked with the doctor who did your took the sample, checked with the lab, and unfortunately, it is your result.
But I was told by the doctor who did my camera test that everything looks good and I should be okay. This is a shock to me, and I was going to go on a holiday, with my husband. He's not been very well, and I just thought I'd take him away, just to clear his mind. His Parkinson has not been very, very good on him. And who's going to look after him? I mean, when I'm not well myself.
I'm really sorry, and I know this must have come as a shock to you. I want you to know that we won't leave you alone with all of this. We've got good support. I will involve the Macmillan nurses. I will get support for you and your husband. We'll get the psychologists, the counselors if you need to. But you're not alone in all of this. We will be there for you every step.
I'm traveling with my husband abroad for 4 months. Can it wait?
Unfortunately, when it comes to things like cancer, it's very important that we start treatment immediately, just so we can control the spread of the disease. So
Okay.
I would advise that we need to start the treatment as soon as possible.
What treatment are you talking about?
So firstly, we would refer your case to the MDT, which is a group of specialists. They would have a look at these results, and most likely they will be offering to do surgery for you. No, it's high grade. They'll be offering. They'll offer to do surgery for you. And if they think that you need some additional treatment, like having a radiotherapy, they would let us know, and we'll be coming back to you to let you know.
What surgery would they be taking away? What surgery is being planned for me? Do you hear me? Do you hear me? Or have I lost you? Oh, it's not my connection. Anyone else want to carry on? Treatment? Yeah, I think you're getting tired after 2 hours of sitting and watching me talk.
Yes, sir, I want to carry, but I can't open the camera.
So we would want to take.
Yeah, it's fine, it's fine. Just talk. Yeah, I
Okay,
don't
sir.
mind. Yeah,
Okay,
whoever
thank you, sir.
can continue. I don't mind. Whoever can continue. What would happen during surgery?
We are going to make a team of a specialized doctor, which will have consultant gynecologist and a sleep doctor, and a specialized nurse midwife, and a psychological counselor. Then we will make an appointment with the anesthetic doctor, and he will decide about your condition. And then after putting you sleep, we will give incision or your tummy, and and on your tummy, and we will remove your womb, and remove your womb, and after removing your womb we will close your tummy, and after that we will send the womb for the histopathology, and after that staging, after doing staging, we will see that if it will be in early stages, then there will be no need of any beam therapy, and if it would
I would
be
say I would say that when you're not wrong by saying that, but assuming usually high grades require treatment, usually adjuvant depending on is high grade, but the type of cancer and the abnormal features like mouth and LVSI as well. My point is that you're correct. You should say like it's a major operation involving keyhole surgery or robot surgery, depending on the surgeon. It's done under general anesthesia. We plan to do a full hysterectomy to remove the womb, cervix, tubes, and ovaries. And because it's high grade, the doctor would do lymph nodes. Is that clear? Is that clear?
yes, doctor.
I just want to let you know you're not wrong by saying all those things, but this is how you say it effectively.
Okay, so we have to say like this, that we will open your tummy and we will remove your womb, and the neck of the womb and the edges. If the lymph node will involve, then we will remove also that, and then we will close the tummy, and according to the stage of the cancer, we will decide your treatment about giving any additional
Correct.
treatment to you,
Correct.
like beam
I
therapy.
yeah. I think your words are not wrong. I'm cautious how effective the words are. We'll open up your tummy and stuff. That's not wrong. It's correct. But I just want you, to put a punch in your words. It's keyhole surgery, to remove the womb and stuff. Just that helps to,
Okay,
make it
it's
clearer.
okay,
Yeah.
okay, okay, sir.
Yeah. Do you know what I mean? You
Sir,
all
you
know how
told
to say
that
it.
in the cancer we no, no, sir, in the cancer you told that it would be open surgery. That's why I'm saying
Well,
that we will open.
sorry. Let me go back. Yeah. Ovarian cancer, advanced ovarian cancer, always open surgery. Early endometrial cancer, laparoscopy or robotics. Is that clear?
Okay,
Early,
sir.
yeah,
Okay,
early
sir.
stage.
Okay,
Early
okay,
cervical cancer, laparoscopy or early laparoscopy robotic versus open. So the leg trial. But only ovarian cancer open. So the first case ovarian
open
cancer.
surgery. Okay,
Mm.
okay,
You all know the answer. You all passed your part two. I'm just making it better for you. So your choice of words in the station is more pack punching because I think you're trying to maybe think it in too simple terms or maybe make it even more too simple. It sounds not wrong. It sounds less effective. If I
okay,
already taught you the keywords, it's a keyhole surgery, it's robotic surgery, it's a fancier keyhole surgery. We remove it through small cuts. You have better recovery. We also do lymph nodes, this kind of things, okay? And then it's MDT, leaflet, and
okay.
it's likely that you need to have treatment, like post-op radiotherapy.
And sir,
Okay?
after the surgery, we should connect the patient to the counselor.
Yes. NHS, you're not wrong. NHS is not big on funding for counseling services. It's not covered. It's more for Macmillan nurses. So others, nurse specialist is good enough. If the station is only on cancer work, psychology counseling is not big of deal in this station, not the main focus. You can always say your clinical specialist will sort out some psychological support, but it's not the main focus of this. Is that clear? If it's a
Okay,
young
okay, okay.
teenage girl with ovarian cancer or with some aggressive tumor, then yes, those are
Hmm.
important. Is that clear?
Okay, sir. And for the husband of this patient, should we provide support?
Mm. What can you do as a doctor in NHS? You can only do so much.
Okay, okay. Thank you.
What can you do? What can you offer?
Dr. Alex, Sorry to bother
Yes.
you. So you
Yes.
are saying that if this is even high-grade carcinoma, we can offer a keyhole surgery or robotic surgery in this case.
Yes. Yes. Because I
Okay.
do them. I do them. I
Mhm.
do laparoscopic robotic for high grades. That's why the difference in your setting and my setting is that the generalists would do low grade laparoscopy robotics for low grade endometrial cancer. I tend to do, yes, the low grade but high BMIs or difficult surgery versus and the high grades laparoscopic and robotically. This is for early endometrial cancer and early cervical cancer. Okay, early, yeah, early stage, yeah. Ovarian cancer, always open. In real life, we can do what you want, I mean, on your system. But in the exam, open, open, open for ovary. Don't. It's a universal statement. Okay. Should we do one more before we call it a day? I think I've given you a lot of information, haven't I? Next, please. Just one more station. Okay. Does anyone want to volunteer any one of them? I choose these stations to challenge you. So at least you're learning something substantial from this session, not just a simple, introductory demise, which I think you can do very well. It's when I teach you the tricks to fish, you fish very well. Anyone want to volunteer? Anyone? It's gone quiet now. Have I lost connection? Anyone?
Dr. Alice, if someone is not doing, then I'll do. If someone is
Yeah,
doing,
go
then
on, go
it's
on, go on,
okay.
do it. Yeah, I think you all are very tired. Yeah, it's 7:30 here from my side, and I'm doing it on my day off. Yeah. Okay.
Okay,
You
you're
tell
right.
me which one you want to choose. I will fire you questions as though I'm the role player.
Mhm. I can choose the first one.
The first one.
Or yeah,
Can I
or
su- yeah, can I
yeah,
suggest the
yeah.
last one? The last one.
Okay, okay,
Because
okay.
last one's always a controversial issue. So I'm Anne, I'm 29, again, yeah, a young
Mm-hmm.
childbearing age. Heavy
Mm-hmm.
smoker, colposcopy referral due to high-grade dyskeriosis, and
Mm-hmm.
I did a punch, it confirmed CIN3. She
Mm-hmm.
came for a planned LETs with you, but not sure why. And you
Mm-hmm.
found from the reception that she had a one night stand last night.
Okay, all right.
So yeah,
So
so
and
yeah. So you've confirmed everything. Just tell me, doctor, I'm not sure why I'm here today. I was called in by by the nurse to come in to see you about something being treated. I have no idea,
Mhm.
I mean, what's going on so far. So tell me what's going on, doctor.
Okay, so and as we know that we have taken you have gone through the colposcopy and we have taken some tissue from your neck of the bone, and now we have the results. And I'm really sorry to tell you that the results are showing that you are having a high SIN3. That is a high grade scoliosis. Have you ever heard about this?
No, is this the CIN tree, right? No, no, I'm not
Yeah,
about.
yeah, yeah.
No, no,
So,
no. Please tell me.
so yeah. So, and let me draw for better understanding. So, our neck of the womb is made of the skin cells, and we divide these skin cells into the three layers. Okay, top one, middle one, and the lowermost. So, these high grade dyskeriosis, these are the cells. Basically, these are not normal cells, but they are not a cancerous cells. They are in between. Okay, so it's very important that you have to treat them. So in your case, the SIN3 means that these abnormal cells are occupying all the layer of your neck of the womb, skin around the neck of the womb. Am I clear so far?
But why, if it's not cancer, then
Mhm.
why must I need treatment? And what treatment is there for it? It's not
Yeah.
cancer.
So So, and I'm reassuring you right now, it is not cancer, but its treatment is very important, because if we will leave it as such, then in next 10 to 20 years, in 25 out of the 100 women, it can turn into the cancer. Okay, so like
Okay.
you are in between. Here is the normal cells. In between are the normal cells, and on the one side is the cancerous cells. So you are in between. These abnormal cells turn into the cancerous cells. So right now, treatment is very important for you.
But okay. What treatment is there for me now?
Yeah. So the treatment that we offer is a shaving of the cells. We call that the large loop excisional. We call it the LEDs. So it will be we will do it under the colposcopy, like as you have gone through the previously in the colposcopy clinic. It's a just take care procedure, and there are few precautions which you need to take after this procedure. And we will numb your neck of the moon with the numbing gel, and then we shave, and then we will send this area for the confirmation, and then we will tell you about the follow up as well. Okay.
Okay. Okay.
And
But I had sex with someone who's not my regular partner last night. Is
I,
this, yeah, is this
yeah,
something that, sorry.
so yes, I understand your issue. So as you are having unprotected sexual intercourse, I need to know few more information so we can offer you emergency contraception for this. So, Dr. Alex, I need few information for this.
Oh, yeah, sure. So you got my information, but what are the options for me?
Okay, yeah. So we do have options, emergency contraception are in the form of the tablets, or we can offer you a coil.
Yeah,
Coil.
What coil?
That is a copper coil. Okay.
Copper coil is not wrong in real life, but when in our setting, we would have marina coil.
Okay. Okay.
Okay, so
All
copper
right.
coil, America is not wrong. But if I said what other options are there other than the coil, anything else that you offer me?
Yeah, we have option of the tablets, that is the Ella1 and the Livonel. They both
Yes.
delay the ovulation.
Yes,
So
that's good. So yeah, that's correct. I want you to say Ella1, which works this way, okay, and Lebanel, which works this way, or the copper coil or marina coil. You can put it at the time of the LEDs. That's all correct. Now I make it hard for you. I am a strong Christian. I don't believe sorry, strong Catholic, and I don't believe in birth control, and I believe in this, in the sanctity of life. So even though it's not my regular partner, if I do fall pregnant, I will not terminate, and I will not use birth control. Would you
Okay.
proceed with treatment?
I understand your concern. If you don't want any contraception, then we can as do you have any sexual intercourse before this, like in
I
last 3 weeks?
I got a regular partner. I just happened to be out. I met up with this person who I knew from before. It's a one-off thing, but it was not protected. Hey, if I do get pregnant from this, I will always treasure, the unborn life. I will not terminate. I believe in all lives, are precious
Okay.
and should be preserved. So I don't believe in birth control at all. So thank you for offering me all this, but I do not believe in
Yeah.
that. So would you proceed with the treatment for me?
Yeah, enough. If any any unprotected sexual intercourse has been happened 3 weeks back, then before procedure we will check your pregnancy test. Okay. But
Happened last night.
okay, so from last night, we will check your pregnancy after 3 weeks. So what we can do, that we can offer you this procedure, because at this time you are having seen 3 changes. So it's very important that we should not leave it. Okay. So, and it will take 4 to 6 weeks for the healing of your neck of the bone. In that period, you will not swim, you will not take a bath like in the bathtub, and there can be some bleeding or infection. But in the pregnancy, if you get pregnant, then you have to come for follow-up in the pregnancy, and we will monitor your neck of the bone because it can lead to the miscarriage and early preterm complications in the pregnancy. So it will put you in the moderate risk. So we will check your neck of the womb from 18 to 22 weeks via internal ultrasound. Okay, and
That's
if
correct.
need will arise, we will put the stitch around the cervix, neck of the womb. Sorry.
That's a good answer. Can you assure me that if you do a LETS for me now,
Mm-hmm.
I will not miscarry. This baby will not be harmed.
Uh, the leg procedure usually do not harm the baby because not we are going inside the cervix or beyond the cervix into the neck of lining of the bone, but as this can shorten the neck of the length of the neck of the bone, so it might chances that you can end into the miscarriage or early preterm labor. The baby can deliver early, so
Yeah.
that's why we will offer you the monitoring of the neck, length of monitoring of the neck of the bone, so we can make a proper treatment if it will be short.
I agree with all your advice. I think it's brilliant. You did very well. So it can be tricky because it came up in some stations.
Mm-hmm.
And if this person accepts Lebanel, LR1, sorry, or the coil, it's absolutely fine. Go ahead with treatment. The issue is that if she has a strong religious belief and she's against, having an adverse pregnancy outcome, i.e. miscarriage. In that scenario, in the exam scenario, if you're not sure, it's okay to delay it and repeat pregnancy tests and ask a consultant. Is that clear? Don't commit to
Okay.
it. Yeah, because
Okay.
if you're panicking.
Okay.
But I
So
agree.
Dr. Alice,
Yeah.
the LR1 won't disturb the pregnancy. Can we say that the LR1, if you will get pregnant, the LR will not disturb the pregnancy and it
Oh,
don't
so
have
sorry.
any.
Sorry. I hope I'm being clear. You have two
Sorry,
kinds
sorry,
of patients.
leave on that, leave on that, leave on that, leave on that. Don't.
You have two kinds of patient in this scenario. One who
Mm-hmm.
accepts the birth control and carries out the LATs, which is completely fine for you. I'm not giving
Mm-hmm.
you the difficult one, which is someone who doesn't believe in birth control, strongly
Mm-hmm.
religious, and doesn't want a first pregnancy outcome. That means she doesn't want to lose the baby at all
Mm-hmm.
costs. So this
Okay.
one, I ask you all, would you do a LATs or not, given that she's only had sex with this stranger or a partner out of nowhere last night? In
Mm-hmm.
the exam setting, if
Hi,
you
Dr.
panic,
Alex.
yes, hi.
Just a gentle reminder that it's 7:30 p.m.
Oh,
Malaysian
yes,
time.
yes. I wrap up. Yeah, I wrap up. So if you're not sure in exam, you can say,
Mm-hmm.
I should proceed with the treatment today because it's indicated for CIN3, but let me double check with my consultant next door. Okay?
Okay.
So you're
Okay.
safe. But it's also safe practice say that you do no harm because you're not sure for the if it's safe to do a LETS and not cause a miscarry. How do you know your
Mm-hmm.
LETS will cause a miscarry? There is some element of miscarriage due to trauma to cervix. If you're not
Mm-hmm.
sure in the exam setting and real life, double check with the consultant. Let us bear that burden for you.
Mm-hmm. Okay.
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 So in the
Okay.
exam, if this person accepts birth control, do it, give it, treat her for the CI3. If she's against birth control and she only doesn't want LETS to affect the pregnancy, you can either treat it and ask a consultant first. Is that clear to all?
Okay. So, Dr.
Is
Alice,
it? Yeah.
if we do LETS and we cannot put coil after doing LETS because there is increased risk of bleeding and infection, and before
I
LETS,
normally
definitely it will
I
shave the thread.
I normally put in the coil before I start LETS because trust me, once you diatomize and you coagulate the canal, it will stenose.
Mm-hmm.
You put the coil in first, then do a LETS. So you accept the coil will be shortened, or you can manipulate the coil to do the LETS. Because the
Mm-hmm.
less you can push around. Yeah. Okay.
Mm-hmm. Okay.
Is
Okay.
that clear?
Okay. Thank you.
The 2 hours mark is up, and I do apologize that I can't go through everything because the whole point of this is to give you a flavor of the things that can come out, and I hope I'm giving you all lots of tips, lots of techniques, lots of tricks to bypass, navigate through all these hurdles because they will try to catch you up with all these things. Okay. Is there any burning question before we close up?
No, thank you so much. It was really helpful.
I'd
It is
like to
really
ask a
helpful.
Yeah.
question. Sorry, please.
Yes.
I'd like to ask. So, this patient did come out last exam, and it was CIN3, and she asked what was CIN3. How do you explain that to the lady?
Sorry. Can you repeat yourself? Entry?
So CIN3,
Yeah.
the lady wanted to know. She didn't know about CIN3, and she wanted an explanation of what the condition was. How do you explain to the patient?
Sure. Very happy to. So the way we are trained in the UK is that it's either normal, low grade, which is mild changes, or high grade. Simple as that, okay? Normal, low grade, or high grade changes. With high grade, they are not cancers, they are precancerous, which means that if you leave them alone, over the next few years, they have the potential to become cancer. And that means treatment is definite. This whole treatment of LATs is to treat the precancerous changes so it will not change into cancer, which will involve a far more invasive treatment. So the CIN3 is that it's a high-grade change in the cervix that is not cancerous on its own, but it's precancerous. Which means that if you leave it on its own, or if left untreated over the years, it has the ability to become cancer. Simple.
Yeah, thank you very much.
So these are high-grade changes of the cervix, which are not cancerous but precancerous. If left untreated over the years, it has the ability to become cancer. And we're trying to avoid cancer from forming because it requires far more invasive treatment and more closed-up investigation. Hence, we are here, as colposcopists. I hope I've been informative, conducive, and giving you all lots of tips. When I did it my time, it was a different time. I'm almost 10 years post MRCOG, but those days the keywords were not very, very, very structured, and these are all my techniques, and I passed first time. SD3, and that was the most junior registrar at the time. And no, it's God's grace, and I passed with good techniques and good mentors. But I'm happy to share this with you, so I hope to help you all. Okay. Is there anything before we close up, or should? Okay. Minhal, are you still there? I believe. Should we wrap up then? So I think it's already 7:40 now. All right. I wish you
It
all
was a
the
wonderful
best.
session, Dr. Alex. Hope to
Yeah. Pleasure. It's also a pleasure to help anyone from all walks of life, any gender, any location. I'm happy to be on my leave, so I will help. That's fine. Okay. Do take care, and hopefully we will cross path again. Okay.
we will share tips and tricks in the next session.
Yeah. Oh, yeah. There's other tricks which I can share you more in the future. But I believe you got enough substance from your part 2. You just need to just apply it, rehearse it, control your nerve. It's very easy to say, but control your nerve. Talk slowly. When you pass the exam and get your certificates, you can talk as fast as you want. But for the exam, you must be clear. You must sound logical, professional, and mature, and safe. Okay. Right. I think we should wrap it up. So everyone, I think that's it. Yeah. So anything to add on? Matt Institute. Yeah.
Thank you, Dr. Alex. See you again.
Yeah. Yep. I will log off then, okay? Do take care, everyone. All the best.
Take care. Bye bye.
Bye.